Hello, everyone. My name is Ali Aminian. I'm one of the bariatric surgeons here at the Cleveland Clinic in the United States. On behalf of the Ifso, I'll be moderating the 12th Journal Club today on the prevalence and risk factors of chronic abdominal pain after one-way gastric bypass. This important study was recently published in Annals of Surgery, and I'm very happy and delighted to have two of the co-authors of the study here on the Journal Club. We have Johan Gormsen and Fredrik Helgstrand, and they're going to present their data. They're going to share with us this important study. At the end of the Journal Club, after their presentation, there is opportunity for you guys to type your questions. I'm trying to ask some of your questions from the authors of this study. It's important to know that this Journal Club going to be recorded, and you're going to have access to this presentation on the Ifso website and on the Ifso app. We also have a visual abstract which was created based on the findings of this Journal Club, which is available here as a handout. You can download it. And I think we are ready to start. Without further ado, I'm going to ask Johan Gormsen to start the presentation.
Yes, thank you very much for letting me have the opportunity to present my study here. As Dr. Armenian said, I'm gonna present the results on the prevalence and risk factors for development of chronic abdominal pain after gastric bypass surgery. So I'm gonna start by telling a little bit about the background of the study. So at least at our hospital, we see a lot of patients who complain about abdominal pain after gastric bypass surgery. We have both inpatient and outpatient, and a lot of these patients complain especially of postprandial abdominal pain. So we try to find the cause of this pain by different diagnostic modalities such as ultrasound or CT scan or MRIs. But ultimately, many of these patients end up undergoing a diagnostic laparoscopy, among most of these patients with no pathological findings. But and we are not able to cure them of their abdominal pain. So we did a literature search and tried to find out what could be causing this abdominal pain. And we found a Norwegian study where they found that 50% of the patients after gastric bypass surgery actually get diagnostic images because of abdominal pain. And then we found two studies investigating the prevalence of chronic abdominal pain, which varied between 7% and 54%. These studies did not only vary in their results, but they also varied in their study design and in their definition of chronic abdominal pain, which made them quite difficult to compare. So our aim with this study was to investigate how many patients develop chronic abdominal pain and what characterizes these patients. And then hopefully at one point we'll be able to point out which patients actually benefit the most from having bariatric surgery. So our study was a register-based cohort study where we included all patients who were operated at the Zealand University Hospital between 2010 and 2015. Our operative strategy was standardized, so these patients underwent laparoscopy with a creation of an alimentary limb of 120 centimeters and a root limb of 70 centimeters. And we obtained a lot of data from multiple sources, both from administrative registers and from clinical databases, then from personal medical records and from a questionnaire. And from these sources, we obtained both preoperative, intraoperative, and postoperative variables. I'm going to start by mentioning the preoperative variables where we obtained demographic, lifestyle, and comorbidities from the Danish Obesity Surgery Register and from personal medical records. Then we obtained socioeconomic from the Statistics Denmark, and preoperative medication, where we were especially interested in analgesics from the Danish National Prescription Register. Then we obtained intraoperative data from the Danish Obesity Surgery Register and from the operative reports in the medical records. Finally, we obtained some post-operative information. We got diagnosis codes and operation codes from the Danish National Patient Register, and from this we could assess post-operative complications within the first 30 days of the operation. Then we got data on the weight loss and post-operative lifestyle, such as post-operative smoking, from the Danish Obesity Surgery Register and from the medical records. We got information again on the post-operative medication from the Danish National Prescription Register. And finally, we got some information on the subjective symptoms, such as abdominal pain, from the study questionnaire. So from this, we could define chronic abdominal pain, which we defined as either starting or no, we defined like a general definition where we defined chronic abdominal pain as either lasting or recurring abdominal pain after 3 to 6 months. But we also wanted to include as many patients as possible in this definition, while we also wanted to include the self-reported data. So we split our definition of chronic abdominal pain in two. We had the register-based definition, where we included patients who either started or escalated their use of strong analgesics, and if the patients received a post-operative diagnosis of chronic pain, and finally, if the patients were referred for a specialized pain clinic in the post-operative course. Then we have the definition of self-reported chronic abdominal pain, which we defined as patients with pain more than 2 times per week within the last month, which also included patients with either daily or constant abdominal pain. So now I'm gonna gradually go to the results, and I'm gonna start by going through the flow diagram of the study. So we started out by identifying 800 patients who had gastric bypass surgery in our time frame. Then we excluded 13 patients who were either deceased, immigrated, or who were unavailable to contact because they did not have a registered permanent address. So in the end, we were able to include 787 patients in our study, and of these, 532 patients answered our study questionnaire. 784 patients were registered in the Danish Obesity Surgery Register, and 660 patients gave us permission to look through their medical records for the purpose of this study. And so among these patients, they had a median age of 41 years. Almost 80% of the patients were women, and they had a median BMI of 44. Then 7.8% of the patients had a post-operative complication. This can sound a little bit high, but we define post-operative complications as either readmission or reoperation within the first 30 days of the operation, or if the patients had a need of intensive therapy, or if they died within the first 30 days of the operation. None of our patients needed intensive care treatment or died within the first 30 days of the operation, and most of the patients were registered as having a postoperative complication because they were readmitted, while some of the patients had a reoperation. Then 4% of the patients were smoking, and we had a median follow-up of just over 5 years. So now I'm going to go through the results on the register-based pain. This we were able to assess among our whole population, so among the 787 patients. And among these, 9.8% of the patients either started or escalated their use of strong analgesics. and 3.2% of the patients got a postoperative diagnosis with chronic pain, while 2.4% of the patients were referred to a specialized pain clinic. So overall, this gave us a prevalence of just over 11%. We are not going to go through all of the risk factors, but we calculated our risk factors through multivariate logistic regression, where we adjusted for age and sex, if they had a postoperative complication, their marital status, occupational status, the indication for surgery, if they were smoking, and if they preoperatively had a use of strong analgesics. And the only significant risk factor was if the patients had a preoperative use of strong analgesics prior to surgery. Yes, so now I'm gonna go through the self-reported chronic abdominal pain, which we were able to assess among the 532 patients that answered our study questionnaire. And among these patients, 2.3% of the patients had constant abdominal pain, 10.3% of the patients had daily abdominal pain, while 8.6% of the patients reported abdominal pain more than 2 times weekly. So overall, this gave us a prevalence of just over 21% that had self-reported severe abdominal pain. And the risk factors we again assessed by the multivariate logistic regression, where we adjusted for the same variables as for the register-based abdominal pain. And again, the preoperative use of strong analgesics was a significant risk factor, but also if the patients had a postoperative complication within 30 days of the operation, if they were either unemployed or had a disability pension, and if the patients were smoking prior to the surgery. So from these results, the most interesting of the risk factors for us was the preoperative use of strong analgesics, which was a significant risk factor for both groups. So we wanted to visualize the yearly use of strong analgesics from postoperatively to 5 years preoperatively to 5 years postoperatively, which we visualized through a penalized B-spline curve. And I'm going to start by describing the register-based chronic abdominal pain, where we see a substantial increase within the first year of the operation, which was expected, as this is part of our definition of chronic pain. But we also see that the use is actually the same, quite the same over the next 5 years, which indicate that this is not just a transient increase in the use of strong analgesics. Then we're going to go to the self-reported chronic abdominal pain, which is the middle curve, where we see a significant increased preoperative value, but the development is actually quite similar compared to the overall population, which we have on the curve just below. This is quite interesting, as actually in our questionnaire, 50% of the patients with self-reported chronic abdominal pain reported that they used analgesics on a weekly basis, but they also reported that they used paracetamol, which is a over-the-counter analgesic in Denmark, and which is considered a mild analgesic. So from these results, we imagine that the patients that we have defined as the register-based chronic abdominal pain patients are the patients that we see on a weekly basis in our outpatient and inpatient clinics, but that are actually almost twice as much patients with chronic abdominal pain that we just don't see in a hospital setting. So from this, we concluded that 1 of 10 patients have chronic medically treated pain, while 1 of 5 patients have subjective frequent abdominal pain. And the risk factors were if the patients had a preoperative use of strong analgesics, if they had early complications, so complications within 30 days of the surgery, if they were smoking preoperatively, or if they were either unemployed or had a disability pension preoperatively. So now I'm just briefly going to go through the limitations and strengths of this study. So our primary limitation was that we were not able to differentiate between the indication for the use of analgesics. So we know that a lot of our patients have arthrosis and arthrosis-related pain, and this could also be an indication for use of strong analgesics. Previous studies showed that that actually the arthrosis-related pain is better in the postoperative course, and a lot of patients have a better physical function, which leads to decreased use of strong analgesics in the postoperative course. But this is still a substantial limitation of our study. Then it can be questioned whether abdominal pain within the last month can be considered chronic. If we go back to our general definition of chronic pain, then we included pain that was either lasting or recurring within the last 3 to 6 months of within the last 3 to 6 months. And we thought about asking the patients about pain further back, but we meant that this could lead to a quite substantial recall bias. We could, and then we could also have asked the patients repeatedly over a period of 3 to 6 months. But considering how difficult it was to just get the patients to answer this one questionnaire, this was not considered realistic. This could be considered a limitation, but we actually don't consider it that substantial a limitation when we consider the long follow-up of the study. So if the patients had weekly abdominal pain 5 years after their surgery, they with most likely also had it within the last 6 months. So now I'm going to go to the questionnaire answers, and 68% of our patients answered our questionnaire, which we consider to be acceptable, but it's still difficult to know whether the patients answered the questionnaire because they wanted to express symptoms or because they wanted to express satisfaction with the surgery. And it's difficult to know which one of these actually weighs highest. Furthermore, the questionnaire was actually developed for a different patient group. It was developed for patients who had undergone a small bowel resection. And we validated the questionnaire internally in the bariatric center, but this is still a limitation of our study. Then we have the register-based limitations. We have, there are some different register-based limitations, such as residual confounding and missing values, which was actually minimized in our study because we obtained our data from multiple sources. And that way we could include all the variables that we found of relevance, and we did not have that many missing values. Furthermore, there's also a risk of misclassification if some of the values could have been input incorrectly into the databases. But we consider the register-based limitations of this study quite minimal overall. Finally, I'd like to go through the external validation of this study. So we had a quite large cohort, but a single center study, which means that the study have not been validated nationally or internationally. We believe that the tendencies in the results are valid nationally, but it would be quite interesting to validate the results internationally. Yes, so now I'd like to move on to the strengths of the study. So we obtained the data from multiple sources, both from administrative registers, from clinical databases, from the questionnaire, and from the personal medical records. This ensured that we had a quite high completeness. We had a completeness of 94% of the data across all sources. And this also ensured that we could get a long follow-up and a national follow-up on all of our patients. So even though the limitations are that the list is quite longer than the strengths, we actually believe that the strengths of the study way higher than the limitations of our study. So now I'm gonna go on to the further perspectives, where we would like to have future research focus on. So one of the things that we believe is quite important is a development of and validation of a tool for assessment of chronic pain that could be used in the future, so that future studies could be more homogeneous and they could be easier to compare. Also, we thought it would be quite interesting to investigate the causes for post-operative chronic pain. There are some hypothetic causes, such as adhesions or intermittent internal hernia, but these causes should be fixed by the operation. So if you perform an adhesiolysis or if you close the mesenteric defects. But there are also some hypotheses about the change of anatomy. So there's a risk of trancocelicus compression syndrome among patients after bariatric surgery. Also, there could be some level of localized mesenteric ischemia, especially around the anastomosis. A lot of these patients are quite comorbid, also with cardiovascular comorbidities, so they are in risk of development of abdominal angina, but this has not been investigated in previous studies. So that would be quite interesting topic for previous studies. So also it would be interesting to both to develop some preoperative, intraoperative, and postoperative interventions, both in order to select which patients should be operated and in order to prevent the development of chronic pain among the patients that are operated. And finally, we think it would be quite interesting to compare these results with the results among other types of bariatric surgery, such as sleeve gastrectomy. There are still no results on this topic among the patients with sleeve gastrectomy, which is one of the most popular surgeries, at least in Denmark right now. So that would also be quite interesting for future research. So that's what we have for now, and we'd love to answer any questions.
Thank you. That was a very important publication contribution to the field. Joan and Frederick, I congratulate you, and that was a very nice presentation. So as a bariatric surgeon, as you mentioned, we don't know what to do with this type of patient and this complication, which unfortunately is not uncommon after gastric bypass, and we can see it early, post-op, until the very late follow-up. So as a surgeon, we need to know. So for me as a surgeon, the most important piece is to identify the pre-op risk factors, especially if we have a modifiable risk factors that we can work on that before surgery to decrease the risk and prevalence of this complication afterwards. I have few questions, and then I can open the floor. I can ask you the question that I received from the participant in the journal club. So the first question, as you mentioned in the limitation section, is about the quality of the registry that you use. Most of these data came from the different registry. How good is the quality of the registry that you use? How accurate the data was that? Can you ensure that make sure that the data were good quality?
Yeah.
Yes.
You want me to answer? Okay. Or
No, it's okay. Actually, there are a lot of quality assessment on these registries, so we know for sure that the quality is quite high. Also, as we saw in the results, 784 patients out of 787 patients were registered in the Danish Obesity Surgery Register. So actually, we know that we know that every one of the patients are registered in the registries, and we know that the quality, especially among the administrative registers, is high.
Yeah, I can just add that all these registries, they are been validated several times, and also each patient in Denmark have their own unique social security number, and this number are used in every time you go to somewhere in the healthcare system, regardless whether it is public or private settings. So every time you go into the office, it will be registered whatever we are what we are doing with the patients based on diagnosis, of course. And if we are not doing this, we will not be able to get payment for our procedures or whatever we do in the outpatient clinic. So they're very high validation, at least 95% for all of them.
Okay, yeah, that's very good. So the other question that I had is that you showed that 1 out of 10 patients was on analgesic after the gastric bypass. But do we know that you briefly mentioned that? But just to rephrase that, do we know that the indication for the use of analgesic was for abdominal pain, or it could be for any other type of pain, and we don't know? Could you differentiate that?
That was hard to differentiate from our data because we don't directly have the indication of the strong analgesics. But we had some different measures that we used. We only assessed it for the first post-operative year, which means that we did not use the second year, the third year, the fourth year, so that it was most directly linked to the bariatric surgery. Also, we excluded patients who were concurrently in treatment with other anti-epileptics or other antidepressants, so that tricyclic antidepressants and gabapentin and pregabalin was not used for those disorders. But it was difficult to differentiate whether the patients took it because they had arthrosis-related pain or because they had abdominal pain. And for some patients, it might be a combination. So that's quite difficult.
Okay, so the part of the data that came from the registry, so you couldn't differentiate the indication for analgesic, but the part that came from the questionnaire, you could differentiate it.
Yeah, exactly.
Okay.
We try to define those out of it, but there are, of course, some limitations in that area. I agree.
Okay, very good. And so the other question that I had, and a few other participants asked, is that could you differentiate the anatomical cause of the abdominal pain in your series, like what percentage had gallstone-related abdominal pain, marginal ulceration, adhesions, internal hernias, those typical cause of abdominal pain? We know that some patients may develop these, but we have a large group of patients who do not have any of these anatomical causes and still suffer from the pain. So could your study differentiate between the different probable causes of abdominal pain?
We could not directly differentiate this, but among the patients that had gallstones, we would investigate this with the ultrasound, and then we would remove their gallbladder, and that way we would have cured them for their gallstones. And the same thing for the marginal ulcers. We would perform a gastroscopy, and then we would give them some kind of pantoprazole or something like that in order to cure them of their ulcer. So that way, what we meant with this definition was that if the patients were in some kind of permanent treatment with analgesics, then it was because they had a problem that we could not fix with gastroscopy or with removal of their gallbladder.
Okay.
Yeah, so if we have a patient having a cholecystectomy, for instance, we would suspect that the pain, it will have a effect on the pain within 3 months after surgery. But if they had pain after 3 months, then we will suspect that it was of no help to do the surgery. You understand?
Okay.
Yeah.
So you excluded the patient who had short period of the time.
Exactly.
If that pain could resolve with any intervention, those patients were not included in this study. Okay.
Yeah, but it would be quite interesting to see it in a different study, to include these patients in a different study and see how much of how many patients do get different kinds of long-term post-operative complications. But there are actually several studies on this field. There are several studies investigating how many patients get cholecystectomies and marginal ulcers and internal hernia. So we wanted to investigate this among the patients with unexplained abdominal pain.
Okay, very good. So some questions from the floor, from the participants. One question is, so all these patients had laparoscopic gastric bypass, not open, right?
No.
Yes.
Oh, yeah.
Okay. And what technique did you use for the gastrovaginal anastomosis? Circular stapler, linear, hands-on?
The linear stapler. We use actually the Lenrod technique for all of them.
Okay.
Linear stapler.
And in Denmark, you surgeon, do you close the mesenteric defects for all patients?
Yeah. In this case, there were in the start of the study period, there was no consensus regarding closing the defects. So many of these patients in the beginning of the study have not had their defects closed, but have been reoperated for internal herniation, then excluded if that helped on their symptoms.
Okay. And do you routinely prescribe prophylaxis for gallstone after the bariatric surgery?
No.
Okay. There is another question again about the marginal ulceration, and asking that the marginal ulceration can be a chronic condition. Patient may have pain with marginal ulcer more than 1, 3, or 6 months. So, but you couldn't differentiate, as you mentioned, if the patient had chronic pain for specific cause.
We had at least 2 years of follow-up when we started the questionnaires. But of course, we cannot differentiate after that yet. But we have done gastroscopy and so on, and treated the marginal ulcers if we could, of course. And after this study, actually, we have intensive been more careful not to operate on smokers. So we test all patients now with urine creatinine tests before surgery, and if they still continue to smoke, regardless of our recommendations, we avoid operating on them.
Yeah, so that was important finding for me. So you show, John, on your slide that 24% of patients were smoker. So was that, so that included current smoker and former smoker, or you're advising patients to stop smoking months before surgery?
Only current smokers. But it's actually quite interesting when I went back to the when I went into the data and I included the post-operative smoking, then a lot more patients smoked post-operatively than pre-operatively. So we have a theory that maybe not all patients told us that they were smoking pre-operatively.
Yeah.
Okay. So
a small study regarding that, where we actually tested all patients. Before we started doing this routine test, we tested patients and asked them whether they were smoker or non-smoking before surgery, and we found that 20% of patients actually 50% of smokers, previous smokers who told us that they stopped smoking, were still smoking on the day of surgery.
Yes.
That's very interesting. So that's something we really have to deal with. So now you cannot be referred to our hospital if you're not stopped smoking, and then we also will do the testing to be sure.
Yeah, that's very important. And as you mentioned, if we force the patient to stop smoking before surgery to get the surgery, many of them restart smoking afterwards. So,
Yeah.
so
And
that
that's a
that
big problem, and we cannot do something about that.
Yes.
so I mean, so that's why here at the Cleveland Clinic for the gastric bypass, we ask the patient to stop smoking at least 6 months before gastric bypass to show that the patient can be away from smoking at least for a long period of time. That may decrease the risk of recurrence after the surgery, but still about 80% of the patient restarts smoking after the gastric bypass. And as you've shown, that could be a risk factors for the chronic pain, probably related to marginal ulceration.
Yeah, I agree.
Okay.
With our recommendations is 3 months at least, but minimum 3 months. I agree.
Okay. Very good. So how about the analgesic? So there's a question that do you know what percentage were on the narcotic or NSAID or Tylenol? What type of analgesics? What was your definition for patient who was on significant analgesic medication?
It was if the patients were using either opioids, opioid analogs, gabapentin, pregabalin, or tricyclic antidepressants.
Okay, but do you have the breakdown? What percentage was
I believe that we have this in the
opioid after surgery?
Yeah, I can't really remember it, but we have it in our paper.
Look it up.
But I actually think we have it maybe in our supplementary table, if I remember correctly. So we have it someplace in our results, but
it probably 80% were on opioids.
Yeah.
In that figure.
Most of the patients were treated with opioids, especially if they started using strong analgesics. So if they escalated their use of strong analgesics, more patients used gabapentin, and very few patients used tricyclic antidepressants.
Okay, fair enough. So how about there's a question about the other outcomes in patients who had chronic pain after gastric bypass. Did you have like weight loss data, diabetes improvement data, quality of life data on these patients?
This is actually quite interesting. We're just about to publish another paper where we're gonna include both quality of life data and data regarding the occupational outcomes among these patients. But we didn't include it in this paper.
Okay, but can you share briefly? Did you find were they still happy? The quality of life improved despite having the chronic pain, or
the quality of life still improves, but it improves a lot less than among the patients without chronic pain. And actually, the interesting thing is that we also have preoperative measurements on these patients, and the preoperative quality of life, it's the same among the patients who develop chronic pain compared to the patients who did not develop chronic pain. So that's quite interesting.
Okay, very good. I'm going through the questions.
There was no for this paper. There was no indication that they might have a little less weight loss in the chronic pain group.
Yeah,
but not significant.
Okay, very good. So I have a question. Did your finding change your practice in terms of choice of surgery in patients who are on long-term analgesics preoperatively, or in patients who smoke before surgery?
Yeah, I can. Yeah, of course, we are very in patient smoking is abandoned, of course, as I told you, but also we are very careful not to operate on patients who have used a lot of painkillers before surgery, and if so, we tend towards gastric sleeve, although we have no data about gastric sleeve yet. But probably they have a better. It is due to the hypothetic maybe theory that they will have a better effect of the painkillers afterwards.
Yeah, that's like a very important risk factors, and then we can try. There is no data, but we can try the other procedures in those patients who smoke, or patients who are suffering from chronic pain and who are on large dose of narcotics and painkillers before surgery. So in our practice, if the patient comes with fibromyalgia or any of these rheumatologic disorders on multiple pain killers, so that would be relative contraindication for gastric bypass in our practice.
In ours as well, I totally agree.
Okay. I think actually in the beginning, I could see, and when I read through the medical records, that actually a lot of the patients that we operated back in 2010 and 2011 had conditions like fibromyalgia, and we don't operate on these patients anymore. So I think we have changed our practice in this way, that we don't operate on the patients that use a lot of preoperative strong analgesics or have any preoperative chronic pain.
Yeah, hopefully, I hope with all these modifications that we learn from these studies, then we're going to see less and less chronic pain after the gastric bypass in future studies. That would be very hopeful. Okay, let me see what else. So I have a question about the pores that you use during the surgery. 12 millimeter pores, 5 millimeter pores, how many pores that can contribute to chronic pain? Do you close the port sites?
Yeah, we do it. We use 3 12 millimeter ports and 1 5 millimeter, and then we have not a port, but we have a liver retractor in the just below processus xiphoideus, and we close the ports if possible.
Okay.
But not routinely. If in very obese patients, we don't close it, because then and we very rarely see actually port site hernias in these patients.
Okay.
We have looked into it for a more general population in Denmark, where we took 120,000 patients, look into whether they were operated for port site hernia afterward, and it was less than 3% who had a port site hernia with a 12-year follow-up. And it was much lesser actually for the obese patients, but again, we don't have a real hardcore data for it.
Okay, very good. So Frederick, I think we can wrap up this journal club. If you can summarize in 2 minutes the importance of this study and what did this study add to the literature, I would appreciate that.
Yeah. What we can summarize here is that we have an issue here. We have patients undergoing gastric bypass who are unknown for us. We have patients with 10% we see in the outpatient clinic with a lot of complications with pain, which we don't have any clue about why they have this pain. But we can see that we can try to prevent it with preventing them from smoking. And then we have this black box of patients which probably we only see the tip of the iceberg, and the rest is out there, and we have to somehow try to look more into these patients to find who they are and what to do with them to treat them better. And it will be very interesting for the future to see if we should do some more personalized surgery to not just choose between gastric bypass or gastric sleeve, depending on what weekday it is, but also try to look into this matter regarding pain when we choose the right surgery for the right patient.
Yeah, that would be great. And I'm going to add to your summary that you found that preoperative use of strong analgesic unemployment or retirement, post-op complication, and pre-op smoking were significant independent risk factors of chronic abdominal pain after gastric bypass. Anything else you want to add?
No, I couldn't have done it better. Thank you.
Thank you very much.
Thank you. Appreciate your time and your presentation, and congratulate you again for this nice study. Very well done.
Thank you for inviting us.
Sure. Thank you, everybody, for joining us. As I mentioned in the beginning, this presentation has been recorded and will be available on the Ifso website and the app. We'll see you next month for the next Journal Club in the month of July. Thank you, everyone. Have a good day.
And if I can just add on, if you're most welcome to contact us if you have any further questions or anything you would like us to explain further, of course.
I think if anyone needs the full text of the manuscript, they can email you, and you're going to share the manuscript with them.
Yeah.
Right?
Of course.
Have a good day.
You too.
You too. Bye.
Bye.
Let me bare stoppe screening i hvert fald.